Good evening, friends. Now we are going to discuss most important topics of psychiatry. Yes, we will try to cover all previous year questions and the updates in psychiatry. We start first topic, histrionic personality. Yes, what a histrionic personality? I do remember Rakhi Sawant, Poonam Pandey as histrionic personality. Although I can't say that they are having histrionic personality or not, but they always want to be center. We are going to discuss most important topics of psychiatry. Yes, we will try to cover all previous year questions and the updates in psychiatry. We start first topic, histrionic personality. Yes, what a histrionic personality? I do remember Rakhi Sawant, Poonam Pandey as histrionic personality. Okay, there was some to watch comment. So it was having sound. So now it's okay. Okay. So chat. Sorry for this interruption. Yes. They want to be center of attention. They are dramatic, exaggerated emotions. You all have seen any issue in the industry or in India, they will comment. They behave in sexually seductive way, use physical appearance. Now, a question was asked in AIMS, a person who is shy, emotionally cold, introspective, prefer solitary activity, reside alone. Yes, these are features of schizoid personality disorder. Schizoid. Although schizoid are not shy, many times we do remember schizoid as shy. Okay, schizoid as shy means they prefer to remain alone. They will be sitting in library since morning to evening without girlfriend. Okay, and yes, they will like to play alone. They will play only those games which can be played alone. Okay, schizoid personality. Now, paranoid personality, they are suspicious, over friendly act. They keep grudges for long time. Third is emotionally unstable personality disorder. You will remember, yes, schizoid, I have already discussed, prefers solitary activity, emotionally cold, detached, indifference to praise or criticism, little interest in sexual activity. Okay, so solitary activity, schizoid personality disorder. What about other? Antisocial. To remember antisocial, you will remember Salman Khan. Although I don't say that Salman Khan is having antisocial personality, but you can remember. Dissocial or another name. Unlawful behavior. You have seen so many cases on Salman Khan. No regards for the right of others means footpath. Yes, the person who is sleeping on footpath is having his own rights. Lack feeling of guilt. No empathy. Yes, Kala Hiran maar diya tab bhi guilt nahi aaya. No empathy. Don't learn from past mistakes. So many girlfriend left him, but he never understood how to make girlfriend happy. Extreme sense of right. Substance use disorder. Allegedly, it is said that Salman Khan had taken alcohol while he was driving the car, or his driver was driving the car. We found that some biological correlates. They have low resting heart rate. Question was asked in JIPMER. Low resting heart rate. JIPMER question, XYY is related to criminal behavior. Borderline, many times questions are asked. They will give you image in which multiple linear scar mark over forearm. Multiple linear scar mark over forearm. Yes, they have self-injurious behavior. They have splitting. Black and white view question is asked, what is splitting? Means either good or best. Better to say either best or worst. Means suppose this girl, yes, borderline is more common in female than male. If a girl met a boy in the morning, started saying that you are the best person I have ever seen, exchange the number. In evening, she called, boy did not pick the phone. She started saying, you are the worst person I have seen ever. Okay, so either best or either worst. No mid gray zone, that is called black white view or splitting defense mechanism. So question is asked in borderline. Emotionally unstable, impulsivity on small issue, they will become impulsive, they will cut their wrist, they will harm themselves. So intense but unstable relationship, I gave you example just like boy met in the morning and evening breakup. When so many breakup, so many unstable relationship, chronic feeling of emptiness would be there. Treatment, question has been asked on treatment. The treatment of borderline is dialectal behavior therapy. Okay, mnemonic, self-injurious behavior, die. Okay, to prevent death, yes, dialectal. You can easily tell the answer. Yes, please. Yes. Okay. Recurrent suicidal tendency. Yes, in this session I will try to summarize all the important topics, dear. Okay. Yes, paradoxical suicide we will take care. Yes, this is not paradoxical suicide. This is also called para-suicide sometimes. The word para-suicide means new name according to DSM-5. This can be asked. Non-suicidal self-injury. Non-suicidal self-injury. Okay, para-suicide means they don't want to commit suicide. Non-suicidal, but they injure themselves. Okay. Yes. Recurrent suicidal tendency, interpersonal relationship aberrant, black and white phenomena. Answer is yes, borderline personality disorder. Now, very important topic. Most of time you will find a question, okay, on this. Schizophrenia or psychotic disorders. Psychotic disorders. In psychotic disorders, there are delusion, hallucinations. We all know delusion and hallucination are psychotic symptoms. If a patient is there or clinical question is there and they gave delusion is there, hallucination is there, 2 symptoms. Means I have pointed out 5 symptoms, but most of the time you will find delusion and hallucination in question. So if 2 symptoms are there out of these 5, yes, delusion, hallucination, disorganized speech or formal thought disorder. Informal thought disorders, neologism, coining of new word, yes, whose derivation cannot be explained. Suppose I am schizophrenic patient and say this is Dinchek, this is pen, this is not Dinchek, Dinchek is only puja, you all know. Yes, so neologism means coining of a new word. I coined a new word for this pen. Okay, this question has been asked that neologism is seen in schizophrenia. It is most characteristic formal thought disorder found in schizophrenia. Other formal thought disorder you all know: tangentiality, yes, incoherence, yes, loosening of association. So many times you will find questions in which either they will give patient is having delusion and incoherence. 2 symptoms are there, and if these 2 symptoms, out of these 2 symptoms are there for more than 6 months, the diagnosis is schizophrenia. If same symptoms present from 1 month to 6 months, then diagnosis is schizophreniform disorder. Schizophreniform disorder. Okay. If less than 1 month, then brief psychotic disorder. Brief psychotic disorder. Okay, point it out, I highlight it because many times you will find question in which they will give symptoms, only one symptom is there, hallucination is there, delusion is there, less than 1 month, diagnosis would be brief psychotic disorder. In these I told you at least 2 symptoms, brief psychotic disorder, 1 symptom less than 1 month, yes, that is brief psychotic disorder. Even if you don't remember so precisely, just remember out of these, if you find 2 or more than 2 symptoms for more than 6 months, diagnosis is schizophrenia. Okay, less than 1 month brief psychotic disorder. But ICD 11, this was DSM 5, now I am talking about ICD 11. According to ICD 11, if these symptoms are there, the name is ATPD, acute transient psychotic disorder. Okay, and in ATPD usually there is a stressor. Why I am telling you? Yes, you will find a question, I will discuss shortly. Yes, stressor is there, just like fever. Means after fever, patient started having these psychotic symptoms. Yes, the best part is that within 1 month these patient would recover. Okay, so ATPD, brief psychotic disorder. And the third name, okay, common name for these two, ATPD and brief psychotic disorder, is acute psychosis. I write here acute psychosis. Yes, include these two. If you want to write here acute psychosis. Okay, now I make a flow chart. It will be useful to solve many questions. Yes, if a patient is there having delusion, hallucination, yes, delusion, hallucination, 2 symptoms are there or more than 2 symptoms are there for more than 6 months, I have already discussed, the answer is schizophrenia. If 1 month to 6 months, you already know the answer would be schizophreniform disorder. Third, less than 1 month, the answer would be brief psychotic disorder, ATPD, acute psychosis. Although ATPD and brief psychotic disorder, little bit differences are there, but for question purpose you can solve question according to this concept. Okay, if a patient came to you having only and only delusion, I take red color, only and only delusion for more than 1 month, for more than 1 month, the diagnosis is persistent delusional disorder, persistent delusional disorder, PDD, PDD. Okay, got the point? In this question I will write, in PDD occasional hallucination may be present, occasional hallucination may be present. Clear? Now, if patient is having only suspiciousness, no delusion, yes, and adolescent, then you will think of a diagnosis that is paranoid personality disorder. Yes, I told you paranoid personality disorder are suspicious or friendly act. Yes, they keep grudges for long time. So this is flow chart how you will solve the question. Again I am repeating, if question is asked, let me give you a question and you will tell me the answer. Yes, ICD 11, no schizophreniform disorder. Yes, schizophreniform disorder is not mentioned in ICD, not in ICD. Good, Shri. Now, yes, I ask you a question, you will give me answer. Yes, suppose there is a patient having hallucination plus delusion. Yes, for 6 months, diagnosis is schizophrenia. Correct. Question, a patient is having delusion plus occasional hallucination for 1 year. What is the diagnosis? Please do reply. What is the diagnosis? Delusion plus occasional hallucination for 1 year. What is the diagnosis? Yes, answer is persistent delusional disorder. Okay. If I remove this occasional word, definitely delusion and hallucination more than 6 months, answer would become schizophrenia. Clear? This was a question. 37-year-old man reports that after a sudden financial loss, there is a stressor of financial loss. Stressor for, very good, sleep. Stressor for sudden financial loss. He developed certain symptoms. He start feeling fearful that someone is about to harm him. Harm, yes, suspiciousness that somebody wants to harm him. That is delusion of persecution. And this is most common delusion in psychiatry. Question has been asked. Most common delusion in psychiatry. Now, persistent delusional disorder we have discussed. In this delusion is there, but they have not mentioned that it is PDD because other symptom we will explore. Yes, could not sleep, eat properly. He also began to hear voices of female, and that voices would abuse him and say that he was useless and should kill himself. Means he is having hallucination. Yes, hearing of voices when there is no one around. Yes, his symptoms stopped after approximately 1 week. 1 week, these symptoms stopped. There was no relevant past history of drug abuse or medical history. So duration of symptom less than 1 month. Diagnosis is brief psychotic disorder. Brief psychotic disorder. Clear? Schizoaffective disorder. In schizoaffective disorder, schizophrenic symptom plus symptoms of affective disorder, mania or depression. Mania or depression may be there. Either mania or depression. Suppose a patient came to you having 6-month history of hallucination, delusion. Means diagnosis of schizophrenia is fulfilled. This patient is having 5-month history of depressed mood. Means depression criteria are fulfilled. So depression plus schizophrenia. Depression is affective disorder. So you will make the diagnosis of schizoaffective disorder. Schizoaffective disorder, depressive type. Schizoaffective disorder, manic type. 2 types may be there. Clear? Now, catatonic symptoms, very important topic. Catatonia. In catatonia, you will find triad of one is stupor. Stupor is triad of 3 symptoms: akinesia, mutism, yes, mutism, and hyporesponsiveness. Okay, this is stupor. Akinesia, patient standing, not moving, mute, not speaking. Hyporesponsiveness, you are asking some question, patient is not responding, that is stupor. Echolalia, mimicking examiner's speech. Echopraxia, mimicking examiner's language. Mimicking examiner's movement. Yes, speech or language. Lalia means language. Praxia means motor movement. So, if a catatonic patient is there, you ask, what is your name? Patient would say, what is your name? Where do you live? Where do you live? This is echolalia. Echopraxia, you did like this and this. Patient did the same thing, echopraxia, and you became so angry that you are copying me. You put the patient on ECT, electroconvulsive therapy, and you know what is ECT. We do remember, yes, putting electrode and straightening of hair we have seen in many movies, but that is not the ECT. Actually, that was a depiction of a direct ECT. I will discuss shortly. For the time being, yes. The treatment of choice, as I mentioned in this way, so you will remember catatonia, treatment of choice is electroconvulsive therapy. modified electroconvulsive therapy, but initial treatment is injection lorazepam. So if they ask initial treatment or medical treatment, then you will say lorazepam. But if they ask treatment of choice of catatonia, then it is modified ACT. Why this is important? This is important because recently ICD-11 and DSM-5 has separated catatonia from schizophrenia. Previously, we do remember even now, catatonic schizophrenia. Previously, we used to say that catatonia is a type of schizophrenia. But now we started saying catatonia is a separate diagnosis. So this may be a question. Catatonia is a separate diagnosis according to ICD-11 and DSM-5. Got the point? Now, separate diagnosis. A question was asked that catatonia is most commonly associated with option A, schizophrenia, option B, yes, you may give answer, affective disorder. Yes, please do reply. Yes, I will wait for your answers. So catatonia, I discuss only 3 symptoms. I mentioned the word triad. Actually, this is not a triad. And in fact, according to DSM-5, I am discussing these symptoms. Out of these symptoms, if 3 symptoms are there, then it is catatonia. But I told you triad of stupor, akinesia, mutism, hyporesponsiveness. Clear? The answer is affective disorder. Answer is affective disorder. We used to think that it should be schizophrenia because we remember that catatonic schizophrenia having best prognosis, and yes, one type of schizophrenia is catatonic schizophrenia. But we found that catatonia is more commonly associated with affective disorders. Now, other symptoms of catatonia, posturing. What is posturing? Image-based question. Suppose there is a patient in ward and you entered the ward. You found that this girl, the patient, is lying in this abnormal posture for hours, for long time. Yes, diagnosis is posturing. Means patient maintain abnormal posture. What I said? Patient maintain abnormal posture for hours. Okay. Now, if you are doing examination, suppose this patient is lying down very comfortably. Yes, you are doing passive movement. Yes, active movement. If I ask you to move the hand, that is active movement. If I hold this hand and move, passive movement. If you are doing passive movement, and in passive movement, I write passive movement, no resistance, and final posture is maintained. Final posture maintained. Final posture is maintained. That is catalepsy. So same image, 3 answers. First answer, if they gave question that this image is given, what is the diagnosis? Patient is lying in this abnormal posture spontaneously for hours, for long time, diagnosis would be posturing. Or if they give question that patient is lying down comfortably, you are doing neurological examination, doing passive movement, during passive movement you felt no resistance and you left the patient in abnormal posture and patient maintained that abnormal posture for long time, then the answer would be catalepsy. But during passive movement, I take different color. During passive movement, resistance present. Okay, and final posture is maintained. Then it is waxy flexibility. Waxy flexibility. Okay, so this is about motor symptom, catatonic symptom. Okay, now a psychotic patient developed voluntary purposeless movement and was once observed to be standing still for hours with the waxy flexibility. Okay, so purposeless movement means patient is having extra movement. I told you in catatonia there is stupor, no movement, but few patients of catatonia may be having excitement, Remember this point. That is called sometimes excitatory catatonia. So in this, patient is having excitation but later on developed, yes, stupor like features, waxy flexibility, so definitely it is catatonia. In catatonia, initial treatment or medical management is injection lorazepam, but treatment of choice is modified ECT, recently asked question. Okay, now yes, if 5-year-old boy is brought to your office by his parents, who says that he has been not speaking at school for last several months. Okay, first of all, I mark the answer selective mutism. Selective mutism, name itself tells you, mute in selected situation. Mute in selected situations. Just like this child is mute in a particular situation in school, patient is not speaking at school, yes, for several months. Parents are concerned because this has impacted the patient academic performance. If patient is not speaking at school, not giving the answer, definitely teacher would think that child is not interested in study, will get less marks, will not be able to give the answer. They are perplexed that these symptoms are present only in school, but patient is normal at home. Okay, means patient is speaking at home very nicely. So selective mutism, name itself tells you, mute in selected situation. At home patient is speaking, in school patient is not speaking, academic performance will deteriorate. Duration criteria is 1 month. In this, several months are given, so diagnosis of selective mutism is fulfilled. You can easily rule out other options. Option B, avoidant personality disorder. You all know personality is formed in adolescence. Question, personality is formed in adolescence. So question has been asked, this personality is formed in adolescence. The age of child is 5 years. So till now personality is not formed. So patient can't have personality disorder. So this can't be the answer. Post-traumatic stress disorder, there is no history of trauma. Yes, trauma. And in PTSD, the symptom profile is quite different. I will discuss shortly. Okay. Autism spectrum disorder, totally different. I have taken that question also. So for the time being, answer is selective mutism. INICET recently they asked question, selective mutism patient have comorbid childhood anxiety disorder. Although selective mutism is also part of anxiety disorder, but we found these children who are having selective mutism, they also have additional diagnosis, just like social anxiety disorder or social phobia. According to ICD, according to DSM, the same disorder, two different names. Yes, recently they have asked question on the recent classification, change in classification, so you can't avoid, okay, or forget this minor difference. And one more important point I would like to mention, in ICD the same diagnosis answer you may find, the name you may find, elective mutism. Okay, so DSM, the name is selective mutism. ICD, the name is elective mutism. So don't get confused. If in the same question they give option elective mutism, answer would be elective mutism. Okay. Yes. Hi friends, any other question? Yes. Now, generalized anxiety disorder. In generalized anxiety disorder, you will find free floating anxiety. What I said, free floating anxiety. Means patient is anxious all the time. When he is reading, he is anxious. He is eating, he is anxious. He is catching bus, he is anxious every time. Yes, patient is anxious. Sometimes we say जीवन के हर पहलू में एंजाइटी आ गई है. Patient is anxious, worried about, excessive worry about each and every aspect of life. So generalized anxiety disorder, duration criteria is 6 months. So continuous anxiety throughout the day, generalized anxiety disorder. Treatment is CBT plus SSRI. Again I repeat, CBT plus SSRI. Most of time you will find that treatment of choice for most of the psychiatric disorder is combination of CBT plus SSRI. All anxiety disorder treatment is CBT plus SSRI except phobia. So I have written next page, okay, but here I can write over here. Yes, all anxiety disorders treatment is CBT plus SSRI, but phobia there is behavior therapy plus SSRI. Okay. What is panic attack? Suppose I am sitting comfortably. Okay. Yes, panic attack. What is panic attack? Suppose I am sitting comfortably, suddenly I have palpitation, breathlessness, chest pain. Yes, I feel I will die. What I said? I will die. My doom day has come. My doom day has come. Why I am writing like this? Many times you will find that in questions you will find that these phrases are there and it will help you to make the diagnosis. Just like generalized anxiety disorder, free floating anxiety word phrase would be there. In panic attack, my doom day has come, I will die, I will go crazy. Yes, these are typical phrases used in panic attack. In this panic attack, symptoms develop. Yes, develop in 5 to 10 minutes and subside up to 15 minutes. Means 5 to 15 minutes the complete episode would be will be gone. Means I developed this palpitation, breathlessness. In 15 minutes I reached to AIMS. Meanwhile these symptoms subsided. But you will rule out all organicity. Means you will do ECG, yes, BP, pulse rate, everything should be checked, because DD of panic attack is, yes, if I am having chest pain, I will think of MI, myocardial infarction, angina, COPD, asthma. These are common differential diagnosis. Okay. Very good evening all. Yes. Now, treatment I have told you that CBT plus SSRI. But in this question, sometimes they ask questions. Suppose a patient came to you having panic attack. Yes, panic attack. Then immediately what you will give? So in anxiety disorder, if you want to get immediate relief, you will give short-acting benzodiazepine. So sometimes in panic attack, you will find question and they will ask, what is the immediate treatment? You will give benzodiazepine short-acting. Okay, immediate treatment. Okay. Now, in this question, a patient has COVID infection around 3 months back. Now the patient present complaints of excessive sweating, palpitation, fear that he is about to die. I told you that's not diagnostic, but many times in question you will find, yes, pulmonary embolism, yes, hyperthyroidism, yes, pheochromocytoma. All these, there are so many differential diagnoses of panic attack, and all causes should be ruled out. Okay, good. So physical examination and investigation do not really reveal anything. The purpose is to rule out organicity. What is the likely diagnosis? The answer is Yes, panic attack. Panic attack. Depression mania, you can easily rule out. PTSD, post traumatic stress disorder, we can easily rule out. In PTSD, what happens? Although there is stressor, yes, objective stressor, large stressor is there in PTSD, but you will find that in PTSD, typical symptoms, yes, avoidance. I take example, suppose there is a person who bought a new car, go to temple with all family member, he came out of the car, bomb blast, all family member died. Now after death of family member, he started having nightmares. In those dreams, he see the same bomb blast again and again. That is intrusive symptom. Intrusive symptom means after bomb blast, patient is visualizing those bomb blast scene again and again while sleeping, nightmares. When patient is sitting doing his work, same image comes in his mind. Yes, that is flashback. Flashback, nightmares. Yes, got the point? Avoidance, now he never use car, he don't go to temple, that is avoidance. Hyper arousal means he remain irritable, decrease sleep. So in this PTSD can easily ruled out, yes, because avoidance symptom, intrusive symptom, these symptoms are not there. If these symptoms are present for more than 1 month, then the diagnosis is PTSD. If less than 1 month, same symptom, acute stress disorder. Although in acute stress disorder, the symptom severity would be less. Okay. Phobia, recently and frequently asked question. Yes, specific phobia, nyctophobia, question was asked. Nycto means mnemonic, night, and for night, darkness. In night there is darkness, so nyctophobia, fear of darkness. Phobia is excessive and irrational fear of things not feared by other. Means different person are having, yes, little bit fear of darkness, but these patients are having excessive fear. Acrophobia, mnemonic, a crow. Acrophobia, mnemonic is a crow. Crow flies on height. Yes, fear of height. Cynophobia, C for canine. Yes, most common canine pet we in India, definitely dog. Cynophobia. Allurophobia, that is fear of cat. Make any mnemonic and tell me also. Mysophobia, my student told me, sir, mess, our mess is having so many dirt and germs. Even in spite of being medicos, we have in our mess dirt and germs. So mysophobia, fear of dirt and germ. Xenophobia, again student told this mnemonic, sir, yesterday my ex met me, she was behaving just like a stranger. Fear of stranger. Now thanatophobia, Thanos, yes, Thanos, fear of death. Pyrophobia, fear of fire. Pyro word, you know. Now before moving further, I will write claustrophobia. Fear of closed space. Fear of closed space. This question has been asked. Yes. In the same question, yes, if they gave fear of closed space, fear of open space, fear of market, means fear of those places, from where escape is difficult, from where escape is difficult, just like market, closed space, open space. Okay. So if only and only closed space, point it out, claustrophobia. If fear of those places from where escape is difficult, then agoraphobia. So when questions are asked, you will mark the answer yes after reading the complete question. CBT is treatment of choice for all anxiety disorder except phobia, where you use behavior therapy. Yes, prefer, in fact. Clear? Now depression, this is very important. I will solve multiple questions with the help of flow charts. Okay, You all know the mnemonic of symptoms of depression. I have taken different mnemonic. Mnemonic is EMI gaps cause depression. EMI gaps cause, yes, E for energy, low energy, M for mood, sadness of mood. Point it out. Sadness of mood should be persistent and pervasive. What I said? Persistent and, okay, fear of marriage. Okay, there must be some name. Okay. Yes. Persistent and pervasive. Persistent and pervasive. Persistent means throughout the day. Means my mood is sad throughout the day. Pervasive means in all aspect of life. When I am talking to somebody, I am sad. I am eating, I am sad. Yes, whatever I am doing, I am playing cricket, I am sad. That is pervasive. Means जीवन के हर पहलू में दुख ही दुख है. If patient is happy while talking to his girlfriend, he is not having depression. Yes, the criteria is that it should be persistent and pervasive. So, but sometimes this pervasive criteria is not fulfilled, just like atypical depression. Atypical, that's why it is called atypical. Atypical depression, there may be reactivity of mood. Reactivity of mood. Okay. Interest, decrease interest. Anhedonia, question is asked many times. Anhedonia means not getting pleasure in previously pleasurable activity. Not getting pleasure in previously pleasurable activity. Yes, previously he used to play cricket and he used to enjoy, but now he don't enjoy playing cricket. Okay. Suppose a patient came to you, says, Doctor Saab, I am not getting pleasure in talking to my girlfriend. Yes, this is anhedonia. Previously I used to enjoy. Okay, it may be, but you will take history properly. There are chances that girlfriend is very old, boyfriend is very old, and it is quite common that you are not enjoying same just like previous. So that is not anhedonia. Yes, that girlfriend is really old or boyfriend is. So in psychiatry, history should be taken in very detailed way so that you can establish the psychopathology. Okay. Guilt, worthlessness, decreased appetite, decreased psychomotor activity, usually decreased sleep. Yes, in this early morning awakening. Question is asked. Means patient would wake up early in the morning, suppose 5 a.m. Normally he wakes up at 7 a.m. Now he wakes up 5 a.m. He tries to sleep again, but can't sleep. That is called early morning awakening, 2 hours prior to normal awakening time. There is reduced latency of REM sleep. Reduced latency of REM sleep. Suicidal thought, concentration, yes, low concentration, that's why forgetfulness. DSM-5 said if out of these symptoms, 5 symptoms are there. How many symptoms? 5 symptoms are there for 2 weeks. Diagnosis is depression. Point it out. Past 5 symptoms should be there and duration of symptoms should be 2 weeks. Suppose a patient came to me having 5 symptoms out of these and 2 weeks are there, I made the diagnosis of depression. This patient also has psychotic symptom. What I said, this patient also has psychotic symptom, means delusion, hallucination. Delusion or hallucination. You will say this is depression with psychotic symptom or psychotic depression. Okay, depression with psychotic symptom or psychotic depression. Yes, psychotic depression. Okay. Question has been asked, what is the treatment in psychotic depression? For depression, you will give antidepressant. What I said, for depression, you will give antidepressant. Okay. And for psychotic symptom, you will give antipsychotics. Okay. If these this treatment is not going to improve the patient is not improving, then you can think of modified ECT. Yes, ECT is indication. ECT is indication for depression with psychotic symptom. Point it out. Wherever you find the word suicide, yes, immediately you will think of severe depression. What I said, if suicide is there, then severe depression. In severe depression, patient is having very low energy plus suicidal thoughts. Okay. Now patient is having suicidal thought, want to kill himself or herself. Yes, he want to die by hanging himself on the fan, but he has no energy to go to market. Who will go to market? Who will buy the rope? Who will hang himself? So could not commit suicide. He is having so severe depression, he was admitted in ward. Now patient was started with antidepressant. Patient is improving. And you discharge the patient. Yes, you discharge the patient. Now patient has improved in energy. Point it out. These energy symptom will improve early than suicidal thought. Yes, thoughts are not easy to change. So many times it happens that when you discharge the patient, what happens? Patient energy is improved, but suicidal thought still persists. You discharge the patient, now patient has energy, will go to market, will buy rope, will hang himself, will commit suicide. That is called paradoxical suicide, means suicide in recovery phase. Suicide in recovery phase. Okay, paradoxical suicide. Yes, so whenever you will discharge the patient, you are concerned with paradoxical suicide. You will always check the suicide risk. You will assess the suicide risk. Got the point? So a question was asked in INICET. It is a really difficult question. They gave the patient is on TCA, tricyclic antidepressant. Now you discharge the patient. Okay, now you are concerned with option A, paradoxical suicide. Option B, yes, cardiac side effect of TCA. Cardiac side effect of TCA. Okay, when we discharge, we are concerned with paradoxical suicide, not about the cardiac side effect of TCA, because if you discharge the patient on a given amount, if you are not going to increase the TCA, there is no risk of cardiac toxicity. So we monitor TCA, toxicity of TCA, monitoring the ECG, monitoring the TCA level. Okay, what I said, we can monitor cardiac side effect of TCA by ECG or TCA level. So which is best to monitor the cardiac side effect? Please do reply. Which is best? The answer is ECG. And we do ECG whenever we increase the dose of TCA. So if you are discharging the patient, you are not increasing the TCA, so you are not concerned about the cardiac side effect, you are concerned with paradoxical suicide. One concept of paradoxical suicide is also there, that we consider that in fact, there was an article, sorry for that, there was an article in which it was found that antidepressant itself increases the risk of suicide. So one concept, that antidepressant itself increases the risk of suicide. Second, paradoxical suicide is suicide in recovery phase. So two concepts are there. Most of time they ask question on this. Okay. So if a patient came to you having these symptoms, 5 symptoms for 2 weeks, you made the diagnosis of depression. But if a patient came to you having only 4 symptoms, means diagnostic criteria of depression is not fulfilled, means only 4 symptoms are there, and for 2 years, means diagnostic criteria of depression not fulfilled. I write here diagnostic criteria of depression not fulfilled. The diagnosis is, yes, diagnostic criteria of depression not fulfilled, depression symptoms are there, and symptom duration is 2 years. How many years? 2 years. Diagnosis is dysthymia. Diagnosis is dysthymia. Question has been asked. So this is dysthymia. 2 years. Now a patient came to me having depressive symptoms. Yes. 4 symptoms, 3 symptoms. Yes. 2 symptoms, less than 5. Okay. If these symptoms are present for 2 years, yes, you made the diagnosis of dysthymia. Now after that, patient started having few more symptoms. Now patient is having total 5 or more than 5 symptoms. Yes, what would be the diagnosis? Yes, that is depression in dysthymic patient. What I said, now you will say this is depression in dysthymic patient. 2 types of depression, that's why double depression. Double depression. Okay. Yes. Now, before moving further, I will solve a question, recently asked question. They gave few symptoms of depression, and they gave that whenever patient is at home, he becomes little bit sad, he is remaining sad, but whenever his friend comes and he enjoy talking, go to watch movie, enjoy the things. And they gave there was a stressor, just like breakup. So I write here breakup. After breakup, depressive symptoms may be there. You must have experienced in your life. Many times it happens after breakup, you are sad, you are not able to sleep, you are remembering her or him, okay, a lot. Okay, so you are having depressive symptoms. Diagnostic criteria of depression not fulfilled. Diagnostic criteria not fulfilled. Okay, sometimes they will not mention about the number of diagnostic criteria. They will mention that patient is enjoying something, some events, just like talking to friends, going to movie, means he is not fulfilling the criteria of depression. Then the diagnosis would be adjustment disorder. Adjustment disorder. Okay, adjustment disorder. In this, treatment is supportive psychotherapy. Supportive psychotherapy. Okay. I usually say, yes, very good. This is adjustment disorder. Breakup. So you must have heard a song, Dil pe patthar rakh ke maine breakup kar liya. Yes, she was so happy. Yes. Oh, means this breakup is subjective stressor. Subjective stressor means response to these stressor depend on the subject. Few persons are sad, few persons are happy, rarely, but sometimes a long relation. Yes, boy want to get out of this relation, girl also want. One day boy said okay breakup, girl was happy, okay it's breakup, now started singing a song, Dil pe patthar rakh ke maine breakup kar liya. Yes, you know the song very well, and you have heard, if you have heard that song, a boy was there who was saying tune bahut acha kiya, you have done very good thing. Yes, now you are open, new boyfriend would come, not like that exactly, but he was saying like that. So that was giving supportive psychotherapy, although we don't give that type of supportive psychotherapy, but you will remember that supportive psychotherapy. But after breakup, if criteria of depression fulfilled, after breakup, criteria of depression fulfilled, then the answer would be depression. And you will treat the patient according to guidelines of. Okay, dear Mukesh, psychoanalysis. I will try to cover that topic also. Okay. Depression. Yes, criteria of depression fulfilled. Then our diagnosis is depression, and you will start with antidepressant CBT plus antidepressant. Can you tell me the answer, or you can tell me the statement is correct or not? Antidepressant are chosen on the basis of side effect profile. This statement is correct or not? Antidepressants are chosen on the basis of side effect profile. Please do reply. I will wait for your answer. Meanwhile, yes, breakup is subjective stressor. Yes, I told you about bomb blast, post-traumatic stress disorder. If you remember, post-traumatic disorder, yes, bomb blast was objective stressor. So PTSD is usually after, it's not a diagnostic criteria. Yes, but mostly you will find PTSD after bomb blast, rape, earthquake, war. But in adjustment disorder, most of time you will find breakup, divorce. Yes, very good, Mukesh. This is, but now latest edition of synopsis, antidepressant are chosen partly. This question has been asked many times. Yes, this question has been asked many times, and this statement is correct. If same question is asked and they gave antidepressant are chosen partly on the basis of side effect profile, this is the now this is the true statement. Okay, according to synopsis, 12th edition. 11th edition, they have not given this word. But 12th edition on the page, same page, only one word is different, that is partly. So this can be a question. Okay. Yes. Very good. That's why now we say partly depend on side effect profile. Now, if I say that after breakup or after divorce, after financial loss, these symptoms appeared, diagnostic criteria depression not fulfilled, adjustment disorder. Now I give you a scenario. There was a husband, wife, after death of wife, yes, death of wife, there would be grief reaction. What is grief reaction? Grief reaction is normal emotional response after death of loved one. What I said, normal emotional response after death of loved one. Yes, I always discuss this topic. Recently, this topic has been discussed in detail in latest edition of synopsis, or included in little bit more detail. So this is a potential question. Okay, and recently they have asked question on this also. After death of wife, husband is very happy according to Facebook, but in real life we consider that after death of wife, husband would be sad. Okay, this is the reality. Okay, don't go with Facebook. Sadness of mood, decreased appetite, decreased sleep. Yes, diagnostic criteria of depression fulfilled. Sometimes you will find 5-6 symptoms are there. All the symptoms of depression are there. Diagnostic criteria are fulfilled. So what would be the diagnosis? Depression. No, it is normal grief. After death of wife, this much of sadness is justified. प्यार नहीं करते अपनी वाइफ से, हैं या नहीं करोगे, फ्यूचर में करना तो पड़ेगा ना, ठीक है, तो इतना दुखी होना तो बनता है. यस, आफ्टर ब्रेकअप, अब तक शादी नहीं हुई, यस, ब्रेकअप हो गया, ठीक है, तो डाइवोर्स हो गया, शादी भी हो गई, डाइवोर्स हो गया, डेथ नहीं हुई, तो वी कंसिडर इट सब्जेक्टिव स्ट्रेसर. इफ डेथ इज नॉट देयर, वी कंसिडर इज सब्जेक्टिव स्ट्रेसर. ओके, And in this, if criteria of depression fulfilled, diagnosis depression. But after death, even if diagnostic criteria of depression fulfilled, it is normal grief. Unless when you will say depression, when mummification. Yes, if mummification is there, what is mummification? Yes, you preserve the body, not allowed. You preserve the all the items of your wife. Yes, you must have seen many movies that after death of heroine, yes, hero has preserved each and every item. This is the same glass by which she used to take vodka. Yes, preserved. Okay, and we said what a passionate love, but if this patient would come to me, I will give antidepressant. If mummification is there, then yes, answer would be depression and diagnosis would be depression, or treatment would be antidepressant. If persistent sadness, if severe anniversary reaction. What is persistent sadness? In grief, sadness comes in waves, but in anniversary reaction, yes, in depression, the sadness is continuous throughout the day. Okay, anniversary reaction means after death of loved one, after 1 year, patient tried to commit suicide. Yes, in the same way as his wife died, he took the car. Yes, same day, same time, coming, I am also coming, we'll meet in heaven. That is anniversary reaction, means tried to commit suicide. If died, will never come to you. If survived, definitely you will treat the patient on the basis of depression, and antidepressant should be given. So these are the points by which you will differentiate normal grief from the depression. So these are the points. Now Kubler-Ross, I have taken question for that also. Before that, psychoanalysis. Yes, I should discuss psychoanalysis over here. Otherwise, yes, I will forget. So psychoanalysis I am discussing. Yes, father of psychoanalysis, Sigmund Freud. Sigmund Freud gave multiple theories. One is topographical theory of mind. Topographical theory of mind. He said mind is having 3 levels: conscious, preconscious, unconscious. If I ask you a question, what is your name? You immediately replied, my name is this. Means the information is present at conscious level. Yes, information was present at conscious level and you gave me answer. So yes, conscious information is readily available. Preconscious. Suppose I ask you, what is the face of class 5th teacher? You are thinking, okay, I can remember. Yes, after some time you recalled. Means information was present at preconscious level and you put some effort and it comes to conscious level. And if you can't remember the face of class 5th teacher, yes, means information has gone to unconscious mind, and anything which has gone to unconscious mind will never come at conscious level except few conditions. So unconscious mind, any information which is present at unconscious mind will never come at conscious level but will determine our present behavior. So Sigmund Freud said that all the psychiatric disorder are due to unconscious conflicts. Yes, childhood experience. Yes, you must have, yes, Edigo I will discuss, that is structural theory of mind. Yes, if you have seen many times, we also discuss this child was having so much traumatic childhood, definitely he developed this psychotic symptom or psychiatric disorder, justified. In fact, whatever experience we have done during our life, all that experience is buried at unconscious mind. All the conflicts are buried at unconscious mind. They never come at conscious level. Because we want that our conscious level should be happy. But in few conditions, unconscious information can come at conscious level. This question has been asked. Few conditions, unconscious information can come at conscious level. Let me explain before that. Yes, how to implement this concept in your preparation. Now only few days are left. Trust me, if you will give attention and you will accept scientifically or believing on me that whatever I am telling you, this is scientifically proven, or better to say, yes, given in literature. Yes, we found that whatever we have learned is present either at conscious level or pre-conscious level or unconscious level. Whatever we have learned is present at, yes, conscious, pre-conscious or unconscious. In exam, whenever we look at the conscious. The conscious is a very small part. This is just like tip of iceberg. Whenever before exam, just like now, you will start evaluating sometimes how much I remember. You will see only this part. Yes, you can visualize only this part, which is tip of iceberg. But actually, in exam, you have much more important part of brain, or better to say mind. Yes, this preconscious is having very high, very large amount of information. In exam, when you concentrate, all this information comes at the conscious level. That's why we say that if you can maintain the attention, then this preconscious information will come. That's the reason in exam, whenever we are over anxious, this information don't help. And few literature has given that if you are positive in a stressful situation, yes, just like exam, then unconscious information which never come at conscious level can come at conscious and helps. So the only thing I want at this time, you should be positive. Okay, you should be positive. Okay, means whatever hard work you have done, trust on that. If you have trust, you have confidence, you don't have anxiety, this conscious information will help, pre-conscious information will help, and unconscious information can also help. Got the point? So questions, what are the questions? Simple question. Yes, information which can be easily assessed, conscious level, which can be assessed by, yes, focusing attention, pre-conscious, which cannot be assessed except few condition, yes, unconscious. In few condition I give you in which it can be assessed. Okay, yes, just like dream. Yes, as Sigmund Freud said, our unconscious mind is having so much of sexual conflict, unconscious conflict, sexual desire, sexual fantasies, and so many aggression is there. A child is born with the aggression and sexual things, both of which are not acceptable, both of which are, yes, not acceptable. That's why nature said that we will keep all these unconscious desire buried in unconscious mind. It will never come at conscious level because sexual thing, aggression is not socially acceptable. That's why there is a barrier here. Here there is a barrier called repressor. Long time back this question was asked, repressor. Means repressor don't allow unconscious conflicts to come at conscious level. Sigmund Freud said, but whenever you are having dreams, that unconscious information can come at conscious level. Yes, you must have fulfilled so many fantasies during the dream. You can't deny. Okay, so unconscious fantasies, conflicts can come at conscious in dream, because in dream you are the only person who is assessing your unconscious mind. Yes, nobody can't see your dream. That's why you fulfill in dream. Second condition, yes, second condition, question was asked, parapraxis, parapraxis or slip of tongue. Yes, I know that this is rapid revision, so I will give a quick, but this is really interesting because after 1 hour many times we get bored, so it will increase our performance. Yes, there was a girl, sorry to be gender specific, there was a girl having boyfriend Amit, now married to Sumit. Yes, boyfriend was Amit, married to Sumit according to social norm. Yes, according to social norm, after marriage, yes, I take here. There was a girl, yes, boyfriend Amit married to Sumit. According to social norm, this Amit will go to preconscious, then it will go to unconscious if not retrieved. Okay. Yes, according to normal social norm, yes, at conscious level, girl should have Sumit. So Amit was forgotten, has gone to unconscious mind. One fine day, this girl was scolding her husband and she said, "Shut up, Amit." Sumit says, "Who is Amit?" She said, no, it's just slip of tongue. It is just slip of tongue. Yes, no, it's not slip of tongue. It is unconscious information which has come at conscious level. Yes, and yes, Sigmund Freud gave the name parapraxis. So these are two conditions by which unconscious information can come at conscious level. Okay. Second theory I will discuss is structural theory of mind. Theory of mind. In this id, ego, superego. Sigmund Freud said that our mind is having three structure. Id act like a child, act on pleasure principle. Superego, parents, just like parents, moral principle. Ego, realistic balancer. Okay. I explain. Suppose, yes, we all have id. Id act on pleasure principle. Yes, everybody of us want to live in big bungalow, to dine in 5-star, to move in Mercedes. Id would say, don't worry, we will get Mercedes, we will get bungalow, we will dine in 5-star. Yes, 4 friends, 2 guns, HDFC Bank, half an hour job it is. Because it is, yes, it act on pleasure principle. It is not related to consequence. It is not concerned with consequences. So it would say, yes, robbery. But superego, like parents, no, what are you doing? No, don't do robbery. Yes, work hard. Go to, yes, clear your entrance exam, then PG, then DM, then you will earn, and trust me, we will never get Mercedes. Okay, that is a different part. But ego is realistic balancer. Ego will say, okay, I will not do robbery, I will not do work hard till last. After this NEET or INICET, I will take rest for few days, will enjoy in Goa, yes, or shopping. Okay, so realistic balancer. Okay, although there are so many things in psychoanalysis, just like transference, counter transference. Yes, if you meet the patient so frequently, sometimes patient start having feeling, yes, emotions for patients, emotions for doctor. Counter transference, doctors emotion for patient. How you will remember? C for counter, C for clinician, okay, or counselor. So doctor's emotion, counter transference, patient emotion, transference. Okay. So now we come to next topic. Yes, recently asked topic BPAD. Yes, BPAD ICD-11 has classified. ICD-10 was not giving this class, never gave this classification, but ICD-11 has said, yes, BPAD1, BPAD2. Yes, BPAD1 mnemonic. In any question, if you find in any question, thank you Ashwani bhai. Yes, I have transference. I have also transference for you. Okay. Counter transference I can't say, okay, but it is a mutual thing. We both can have transference and counter transference. Okay. Yes, but it may be a real love. Okay, no transference or counter transference. Yes, BPAD 1 mnemonic. Any question if you find the word mania, without second thought you will mark the answer BPAD 1. Okay. In BPAD 2, hypomania. I saw a question. They gave question like this: the patient is having depression, hypomania, depression. Diagnosis is, please give answer. Yes, diagnosis is hypomania. Diagnosis is BPAD. You will fill. Another example I take. There is a patient having depression, hypomania, mania. Diagnosis is, please do reply, BPAD 1. If mania is there, without second thought answer is BPAD 1. If hypomania and mania both are given, better to, yes, not better itself, we make the diagnosis of BPAD 1. If hypomania is there, no mania, then BPAD 2. Clear? So if mania is there, without second thought, BPAD 1. Mnemonic, BPAD 1 male female ratio is 1. BPAD 1 prevalence is 1%. BPAD 1 suicide rate 1%, in fact 10% or 5 to 15 you can say. Okay, so in this question, BPAD 1 having equal prevalence in males and females, yes, male and female 1. Bipolar 2 more common in females, yes, BPAD 2 is more common in females than male. 5 to 10% suicidal, I told you that literature says 5 to 15%, yes. If third more common age group is, no, this is around 20 years. Okay, this is the answer. Recently asked question. Prevalence is 1%. This is true. Clear? So BPAD 1, BPAD 2, you know. Now, yes, how you will differentiate between mania and hypomania? How you will differentiate between mania and hypomania? Yes, mania symptoms, you know, over talkativeness, over familiarity. A patient entered the room and shake hand, hello doctor, how are you, what are you doing? Yes, such a poor place you are sitting. I will make a, yes, I will, I will make a new hospital for you. Yes, over talkative. Yes, delusion of grandiosity. I know the prime minister. Yes, I have so much of power. Yes, like that. So mania, patient is there. Hypomania, symptoms may be same. So how you will differentiate? One differentiating point, we usually remember the number of days, but I say no. Yes, you will remember if socio-occupational dysfunction present, then mania. If socio-occupational dysfunction is minimal or no, or you can write like this, minimal or no socio-occupational dysfunction. Okay, first point. So in any question, if you find socio-occupational dysfunction and manic symptoms or hypomanic symptoms, diagnosis would be mania. Second is, if delusion, hallucination are there without second thought. What I said, delusion, hallucination are there without second thought. Answer would be, yes, psychotic symptom. I can write here, psychotic symptom, delusion, hallucination. Diagnosis would be mania. If pseudo hallucination, if yes, pseudo hallucination I have pointed out to solve this question, although sometimes I discuss it later. Yes, fourth, hospitalization. In this absent. Yes, now duration 7 days, 4 days, 7 days and 4 days. If 7 days, then mania. 4 days, hypomania. Now point it out. If a question came and in that question they have given the patient is having symptoms of mania or hypomania, symptoms are more or less same, and they gave patient is hospitalized and these symptoms are present for 3 days. Symptoms are present for how many days? 3 days. But less than 4 days the diagnosis should be hypomania, but patient is hospitalized, diagnosis should be mania. So what should be your diagnosis? Again I repeat, there is a patient having a manic symptom or hypomanic symptom and patient is hospitalized and these symptoms are present only for 3 days or 4 days. Okay, what is the diagnosis? Please do reply. So for the time being, in this question, increased talkativeness, elevated mood, over familiarity, pseudo hallucination. Yes, on the basis of pseudo hallucination, I will mark the answer mania. Although in this question, when this question was asked, they did not give the main point to differentiate between hypomania or mania. In this, with the help of pseudo hallucination, we differentiated. Clear? Yes, if hospitalization is there, diagnosis would be mania. Okay, good, Shri. Now, yes, देख रहा है विनोद, बनाएंगे एक फ्लो चार्ट. यस, एक फ्लो चार्ट बनाएंगे यहाँ पे. I think I should make this flow chart over here only. Yes, you will draw also. Okay, suppose there is a patient having depression. I will make the diagnosis of depression or unipolar depression. If this patient again develop depression, more than one episode of depression, recurrent depressive disorder. The same question they gave hypomania. Yes, if depression and hypomania is there, diagnosis is, please do reply, BPAD 2. In the same question, if they give now, or the same patient, again I repeat, the patient was having depression. Yes, depression, unipolar depression, again depression, again and again depression, more than one episode, recurrent depressive disorder. Patient is having hypomania, BPD 2. Patient is having mania, BPD 1. Patient is having, now patient developed depression. This is called bipolar depression. Point it out. This was unipolar depression. If depression is there and there is no previous history of mania or hypomania, that is unipolar depression. If previous history of mania or hypomania is there, this is called bipolar depression. In unipolar depression, you give antidepressant. In bipolar depression, never give antidepressant alone. Why? Because sometimes these patients you give antidepressant, patient will switch into mania. What I use the word? Patient may switch into mania. Switching. So if patient came to you having depression, previous episode of mania or hypomania, this is bipolar depression, never give antidepressant alone. Always give antidepressant with mood stabilizer, or a combination is quite famous and questions are asked, fluoxetine plus olanzapine. Question is asked. Okay. And if switching occur, then what you will do? Yes, what is the cause of switching? That is antidepressant. So stop antidepressant. Switching, stop antidepressant and start mood stabilizer. So never ever get confused. Sometimes you will think that the bipolar depression we give fluoxetine plus olanzapine. So in switching also we will give antidepressant plus mood stabilizer. No, in this stop antidepressant because the cause of switching was antidepressant. Okay, so this question has been asked. Male patient with history of depression came to OPD, was prescribed imipenem, antidepressant. 1 week later, he was having excessive talk and increased activity. Excessive talkativeness, increased activity means mania, switch into mania. What is the treatment? Yes, stop the current antidepressant and start mood stabilizer. Okay, although antipsychotics are also having mood stabilizer property, but if mood stabilizer word is given, better answer would be mood stabilizer. Okay, continue current antidepressant, no, antidepressant should be stopped immediately. Okay, yes. Now lithium, many times you will find question on lithium. Narrow therapeutic index, yes, what is narrow therapeutic index? Yes, if I say what is the therapeutic level 0.8 to 1.2 milliequivalent per liter. Yes, if more than 1.5 milliequivalent per liter, then it is toxicity. Okay, very narrow therapeutic index means if it is up to 1.2, then it will be the treatment, or it will be treating the symptoms, but if goes beyond 1.5, then it is toxicity. Question is asked that if you are giving lithium to a patient, you will do pre-lithium monitoring. That pre-lithium monitoring, you will assess the kidney function, renal function, because lithium is excreted by kidney. Okay, if kidney is not functioning, lithium will accumulate. Yes, if kidney is not functioning, lithium will accumulate and will produce toxicity. Okay, whenever you prescribe lithium, you will check the serum lithium level after 5 to 7 days. Means suppose I started patient on lithium today, I will ask patient to come on 5th day, 6th day, 7th day, 5 to 7 days. Or if patient is admitted in ward, we will check the serum lithium level after 5 days. How many days? After 5 days of starting serum lithium, after 5 days. Okay, of starting lithium. And when you will take sample, suppose patient took last dose in the night 8 p.m, you will check the serum lithium at 8 a.m, means sample should be taken 12 hours after last dose. 12 hours after last dose. Okay, both questions has been asked. Now if a patient is on lithium, patient came to OPD, you ask the patient to stretch hand. Patient is having tremors. Sometimes you can't visualize these tremors like this. What you do, you put a paper on the hand. And paper would, yes, with the help of paper, you can see these fine tremors. Okay. Yes, fine tremors. So fine tremors. Normal side effect, no need to worry, give beta blocker. But many times you are sitting in OPD, patient is having tremors like this. That is coarse tremor. Yes, this is toxicity. Coarse tremors, toxicity. Fine tremor, normal side effect. Coarse tremor, toxicity. You will check reflex, hyperreflexia would be there. Yes. Coarse tremor, toxicity. You will check reflexes, hyperreflexia would be there. Okay, hyperreflexia. Yes, ataxia, coma, death may occur, and treatment is dialysis. Treatment of toxicity, you may do dialysis. Why? You can remember. Yes, lithium is excreted by kidney, and the alternate of kidney is dialysis. Okay, clear? According to standard classification ICD, only yes PPAD 1 and 2. Yes, this question, now in this question, lithium on for 6 months, fasting. Yes, whenever fasting is there, patient is not taking anything orally, so there may be loss of plasma volume and the same dose may cause toxicity. Present with coarse tremors, hyperreflexia, ataxia. Yes, diagnose. Yes, to make that diagnosis, you will check serum lithium level. Okay, serum lithium level. Individual with a known psychiatric disorder or on treatment and is not a minor can choose to decide. Yes, according to Mental Health Care Act 2017. According to Mental Health Care Act 2017, we found that there is a concept of advance directive. Means I can make a will. Sometimes it is also called living will. Living will. Okay, according to synopsis, this is living will. Okay, treatment directive, mental will, future directive is not the words describe these things. Living will, advanced directive, or living will. In this, I can choose how I should be treated in future. I can make my will that in future, if I develop psychiatric illness and I lost the decision making capacity, what I said, in future, if I lost my decision making capacity, then this will should be, this advanced directive should be followed. Means I am directing you in advance. So advanced directive, yes, living will. In this I write, suppose I say in future, if I develop schizophrenia, suicidal ideation, whatever condition it may be, never give ECT. Never give ECT. I said this, don't do this, don't do that. I made the will. And I said that there is my friend Maggu who used to make mug of soft drink, okay, for me. So Maggu, my friend, is nominated representative. I nominated a person, my friend, my relative, my family member, that if I have not written in this advanced directive, you can ask the treatment by, yes, you can ask the treatment by the nominated representative will direct you. Okay, so I write here, patient is better than advanced directive than nominated representative. Why I am telling you? Because questions can be asked like this. So if a patient came to me, I am sitting in the OPD or my psychiatric unit, okay, patient is having suicidal ideation, or I change the, I am having suicidal ideation, I am having schizophrenia, my decision making capacity is lost. My friend Maggu, yes, nominated represented, took me to you, Dr. Saab, he has jumped from the roof 2 times, he will commit suicide, you know Dr. Saab, yes, he may commit suicide, give ECT. Give ECT, because indication of suicide is ECT. So a patient having schizophrenia, having suicide ideation, yes, came to the OPD or ward or emergency, and now he has written in the advanced directive, never ever give me ECT. So what you will do? Yes, yes, what you will do? Please do reply. Yes, you will never give ECT. You will never give ECT, because yes, advanced directive is better than nominated representative. It is clearly written, you will ask nominated representative only if it is not written in advanced directive. Now, same question, little bit different. Suppose I am having depression, I want to commit suicide, I tried twice, I jumped from the roof twice, but anyhow survived. My fractures, my both legs are fractured. Now I came to you, Dr. Saab, please give me ECT. You saw yes, advanced directive. In advanced directive it is written, never give ECT. Never give ECT. So what you will do? In depression, I am having decision making capacity. Advanced directive should be followed only when decision making capacity is not there. Yes, I am having depression. I know that if I am not given ECT, I may commit suicide. So I am taking correct decision. Means decision making capacity is there. So you will follow me. So in depression, yes, I give you example. In depression, if insight is present and you are having capacity to make decision, so follow the patient. If decision making capacity is not there, then follow the advanced directive. Yes, if not written in the advanced directive, then follow nominated representative. Okay. Now, yes, prohibited procedure, restricted procedure. Yes, can't do procedure at any cost. Yes, direct ECT. Previously, yes, you know, ECT were of two type, direct and indirect ECT. We can give indirect ECT according to Mental Health Care Act, but direct ECT cannot be given to any patient. Sterilization, chaining, Tere Naam movie, you must have seen Salman Khan, not Shah Rukh Khan. Yes, Tere Naam movie chained. So now you can't make remake of Tere Naam. So you can't do chaining now. Procedure that can be done after getting permission from Mental Health Review Board. Yes, MECT to minor. Yes, modified ECT to minor, you can't give ECT to minor, but if you think that it is really required, you will write a letter to Mental Health Review Board that this is a patient, I want to give ECT to this patient. Yes, then if they allow, you can do. Psychosurgery in the same way, restricted procedure. Yes, decriminalization of suicide, decriminalization of suicide. Yes, previously, if you tried to commit suicide, if you died, definitely no need to worry. Yes, but if you survived, yes, you will go to jail for 1 year. But according to Mental Health Care Act 2017, yes, if you tried to commit suicide, there is no jail. So this is very important point, decriminalization of suicide. Okay, other topic I have included in the integrated session with medicine. Most of the remaining topic I have covered here. Yes, it was taken around 10 days back. Other than that, most of the topic, yes, recently asked I have covered. In the last, I would say that have confidence, whatever you have learned till now. Yes, I usually say this, you know, topographical theory of mind. If you have positive attitude, your unconscious information can come at conscious level. Trust me, this is really working. Many students I have seen that who are more confident in the last phase of preparation, yes, they perform better. Many messages I have with my friends, with my students, really they are friends. Yes, they are disturbed because of some family issues, health problem, yes, or wasting of time. But dear friends, these small obstacle will not change your result. Okay, if you have really worked hard, the last phase, if for 2 days, 3 days, 2 days, 3 days you have wasted, don't worry. Everybody has its own personal problem, financial problem, yes, health problem, but these problems are not determining your rank. The hard work you have done till now will determine. The only thing I want, confidence in you. If you have confidence, this information will come at conscious level. Yes, I am pro-Freudian. I have applied this concept in many students and found the result. Trust me, if you are excessively anxious, this information will never come at conscious level. So in exam, you should be very calm, cool, having confidence. The confidence will come only when you will start believing in your hard work. Whatever hard work you have done, believe that. So thank you for patience listening. Best of luck. Thank you.